Very good evening to all our participants present. I would like to request all of you to kindly keep your audio on mute and keep your video on if you would like. I am Dr. Priyanka and I will be the moderator for today's session. Thank you all very much for taking out the time to join our webinar tonight. Now let's dive straight into this. As a dentist, it's our responsibility to deliver not just the best dental treatment to our patients, but also to practice safely while following all protocols and guidelines. Today, we have a very informative and interactive session on the topic of practice safe dentistry and know your limits. This will be presented by Associate Professor Dr. S. Ratnasodhi. Dr. Sodhi is very passionate about education and advocates safe and best practices in our profession. He's a specialist in family dentistry and primary care at Massa University. At present, he is the clinical coordinator at the Massa Dental Clinic in Clinic Sojana Putra. Now, a few updates before we start. There will be an opportunity for a question and answer session at the end of the webinar. So I kindly request for permission for all of you to speak using the chat box. And if you would like to ask a question, you can also list it down in our chat box. This is a CPD session. Points are pending and an e-certificate will be provided and sent to all of you via WhatsApp or email. Now, without further delay, let's begin. On to you, Ready for you, Dr. Sodhi?
Yes. A very good evening to all my colleagues. And I've seen many of my students there. And thank you very much for attending this webinar. And first and foremost, I would like to thank the moderator, Dr. Priyanka, and the real person behind it is Dr. Rupini Arasu, who has been so helpful as Dr. Priyanka is. And thank you so much and welcome to my webinar. My webinar is about practice safe dentistry. See, safe dentistry is a very wide field, but today I'm here to talk on one of the fields that practice safely so that you won't be caught with your pants down. That means negligence wise. Okay, I know now during the pandemic, of course, you all are using all your PPEs and taking all precautions to vet your patients before you start treating them. But for me today, my talk will be more on how to safeguard yourself from missing certain points during history taking and examination, and during your investigative tests, and also regarding your treatment plan. See, I would like to stress that the main cause of negligent thing to happen between you and your patient, or any complaints with your treatment or anything outcome of your treatment, is failure in communication. I find that when you are talking to the patient may not understand exactly what you are saying. And so during the course of the treatment, the patient will agree. But finally, at the point of finishing, you might get a breakdown. And she said, oh, no, you never told me this. So we don't want this to happen. So initially, with the examination part, I like to stress that before I go into that, I work at the Massa University, where I teach the 4th years and final years. And we have got a lot of setbacks now during the pandemic, but we have been coping with lectures online, and of course practicals, simulation we can do, but not on real actual patient care. But anyway, I've been with MASA for the past 11 years, and I hope I will retire diligently with all. I've seen 10 batches of students through me, and they seem to do very well in the government service or on their own in private practice. Yeah, in general examination starts when the patient walks into your surgery. As the patient is walking into your surgery, please pay attention. Well, that's what I tell my students, and I always do that, because the gait, as the patient walks in, you can see him like using an aid to walk, like a walking stick or a Zimmerman's frame. And that will tell you straight away that he's having some problems with his knee, osteoarthritis, or something to do with his joints. And when you see a patient walking with a flip over motion, with his hands rolling forward, you'll know that he's having Parkinson's. So you start making your initial diagnosis, and you'll know that he's medically compromised. And where's the patient sits, please greet him and call him by his name. I think addressing the patient with his name, like Mr. John or Mr. Vijay or something like that, like when you call them, address them and have constant eye contact with the patient. I know I've seen some students talking to the patient, but they have been writing their notes or writing down something. And that clearly shows to the patient that you are not very concerned. So unless you have constant eye contact, the patient will know that you are caring. Okay, so primary care, I mean in dentistry, the patient and dentist must have a good rep. Okay, and if you see faces like in fairer complexion people, you can see this condition where there is a dilated pink area on the zygoma, on the mala area, zygomatic bone area. That is called mala flush, which straight away will tell you that he has got some mitral valve problems. So you know that he is medically compromised. History taking will reveal so many things. This is a very critical step where we shouldn't ignore or just walk through it. See, the first thing, like you have to take the first step, like eye contact and all I've told you. And I think nearly 70% after your intraoral examination, you will come to a diagnosis. And I make it routine that every patient who is over 40 years old, I encourage my students, and they do it, that they record the blood pressure. Because this blood pressure, even though the patient is telling you that he is on antihypertensives, but you have to record it. And sometimes patient will not tell you, although they are on antihypertensive, they might not tell you because they'll think, dentist, no point telling him, what's the use? So you please make it routine that you record the blood pressure. Not as soon as he's seated, talk to him, calm him down, get him used to your chair and your surroundings, and then you could record his blood pressure. So just by using an electronic one, I prefer the sphygmomanometer, but because you need time, and this can be easily recorded by your nurse also. So nothing to, don't worry about losing time, but this is valuable history, okay? And diabetes, yes, you can use a glucometer to randomly check his blood glucose. Some people won't know that they are diabetics. Some people will try to hide, and that is when things can go wrong. if you do not know the truth. So there is no harm in recording the blood glucose level. And of course, this hypopen is your antidote. Okay, I always stress on this. You can classify the status, the physical status of the patient by using the American Society of Anesthesiologists. They have classified the patient into 6 groups. And I always recommend that general practice, when you're a standalone general practitioner, or in a group practice, but just dental, if you don't have a medical clinic nearby. So we classify that as ASA, ASA1, which are healthy, normal patients. So that is a green light for any dental clinic. And ASA2, they are mild to moderate systemic disease, but well controlled. Okay. And they are on medication, and they know what how their status is, and you can also classify them as ASA2. ASA3 is a little tricky. Severe disease process which limits activity. That means they come on a wheelchair, or they are on anticoagulants, very high anticoagulants like antithrombins. So I will prefer, especially I'm stressing this to the younger dentists who have got not much of exposure, that I prefer that these patients must be referred to a hospital dental clinic where they can get better care. Okay, because in case they go into any problems, then of course in the hospital the patient will be managed better. And ASA4 is definitely like a time bomb. And I think I will not tell any of us to handle patients who are in ASA4. So ASA3, you may escape, but still you have to be very, very careful. Okay. And when we go to like extraoral, I want you to find out like in having pedal edema or cough, consistent cough, fever, whether the patient is toxic because of some acute infection. So you have to be really be a medical person for the extraoral general examination. So you can find like petechial hemorrhages for cirrhosis, spider navy we call it, and like extraorally we can see, of course, we all know how to examine extraorally the maxillofacial region, swellings or any discomfort of dysphagia, difficulty in swallowing. But I'll tell you that when I was in hospital Ipoh, I had a patient early in the morning in the hospital where he could not, his mouth was open and saliva was drooping outside. So I was thinking, what is this condition? And when I told him, can you please close your mouth? He said, I can't close my mouth. So that was the first case of dislocation. That was back in 1982, bilateral dislocation of the TM joint. And clinically, I saw the patient. He's fine, healthy, everything was fine, but only thing he could not close his mouth. So dislocation, I know management of it is quite easy to locate the condyles back into the glenoid fossa of the TM joint. But for new dentists, it may be, you may not have enough experience how to reduce the dislocation. So you can see him waiting for you outside your clinic with his mouth open with a towel, wiping off his saliva. So you can immediately recognize the problem. So extraorally, of course, I know every one of you will know any swellings or any lymph node. You can see any open wound due to trauma, anything like that. But intraorally now lately due to this pandemic in India, so far, I mean, I've not seen a case of mucormycosis, which is a fungal infection. But in India, this is very common during this pandemic. And India, they have already reported, they have written a small review note, case history on this. And most of the cases, like 90% of the cases, were due to were seen in patients who have uncontrolled diabetes. So that is a precipitating factor for this fungal growth. And please just keep your eyes open for this mucormycosis, which the Indian physicians are treating with amphotericin B. I don't know why nystatin doesn't work, I think, on this. But amphotericin B and griseofulvin has been used. But mainly they recommended steroids with griseofulvin. Okay, so keep your eyes open when you examine. I know most of the dentists, we just ignore diagnosis of the, I mean, like keeping a watch on the tongue, the floor of the mouth, the buccal mucosa. You have to see the patient as a whole. Just don't go and see the abutment tooth, whether this abutment is okay, whether it satisfies NT's law. But many of us generally just straight away go to the teeth, which I think it is wrong. So you have to examine the patient generally and extraorally, get good history, because history taking is very, very important in dental practice. So of course, records, like I will recommend routine OPG for the first timers. When a new patient comes, you don't know him, you have not seen him before, it will be very, very good, safe records if you take an OPG. So it's a screening radiograph or image where you may miss certain things if you do not take an OPG, like your impacted third molar or any cyst or whatever periapical lesions, bone loss, generalized bone loss. So please, I will recommend that taking an OPG to have a whole thing. Of course, like if you are going to do endodontics and all, then you have to stick on to your IOPA. But even the GDC recommends now full screening, images of your upper and lower jaw. And treatment plan records, I'm also mentioning you your study models, your photographs, and your clinical notes, which should be kept for at least minimum 7 years. But now with the computers in, you can store it up in your pen drive or any, the data can be kept in a small file. So you can always according to the courts, you are supposed to keep medical records or dental records for minimum of 7 years. So this is the next is the treatment plan. If you are going to give a treatment plan to your patient, you have to see from all angles, okay? Whether periodontally sound for bridges, or whether it is worth doing an endo treatment for a broken down molar, or whether the patient needs chrome denture, a removable partial, which will be beneficial to the patient's health, where you can maintain the teeth that are remaining. Okay, we only don't skillfully try to replace what is missing, but we should also have in mind how to retain whatever is remaining. So I think that keywords there will advise you or let you know that which type of denture or treatment or replacement of teeth is advised for the patient. Don't just think of the dollar sign and straight away say, no, you have to go for a bridge, where when you see actually there is grade 2 mobility in the abutments. And I think in that way, you as a dentist, you shouldn't give a short-term treatment plan. You have to try to give where the patient can at least use your prosthesis for 5 to 10 years. So removable partial dentures still have a place in dentistry. When I say removable partial dentures, I mean chrome cobalt dentures, not those gum strippers like how most of us do acrylic dentures, which are cheap and easy to do. It doesn't need any occlusal rest. There is no direct retainers. There is no minor connectors. So you are directing all your masticatory forces in the temporary denture, like an acrylic denture, towards the bone. And your bone will start resorbing very, very fast. So if you give the patient a removable denture, like a chrome denture, and those things have got attachments like occlusal rest, will direct the forces of mastication towards the long axis of the abutment tooth. So classify your case, see what type of design will be suitable for the patient. And I will not be a hero dentist trying to do the most expensive things and the things that like precision attachments, which I'm not very, very familiar with. But don't treat your patients like you want to try it out to show that you can do it. Okay, so please look at all angles that is favorable to the patient's teeth that are remaining. You have to salvage them. Okay, like acrylic dentures, you can go on extracting one by one and adding it to the acrylic plate. But I think you should advise the patient and tell him, give them the pros and cons. Well, he said, no, I don't have money. I can only afford acrylic denture. Then after talking to him and letting him know, let him decide. If he still says economics doesn't allow me, so I don't have much money, then maybe you have to tell him that I'm not doing the best thing for you, but since you request because of financial constraints, I'll do you a removable acrylic denture. Okay, but you have to wait and let the patient know. And I always let them sign the treatment plan. That means they sign the consent. So consent again is very, very important. You don't think that if he signs at your registration counter, the consent, the general consent, that means the mere fact that he is in your clinic, it doesn't give you the right that he has given you a full consent to do any treatment. That consent, implied consent, that is to say that he allows you to examine him. That's all. No intervention. For every intervention, like if you want to do an extraction, there should be a separate consent form. If you want to do orthodontics, you have to have a separate consent form for orthodontics. Okay, so don't take for granted that he has signed the consent with the nurse outside in the counter. It doesn't mean that you can do whatever we want, because always the lawyers can change it. He said that is only consent for you to examine. So please know that you have to have separate consents for separate limits, treatment. And the treatment plan, please note it down, well document the treatment plan, and always we discuss the risks and the complications that can come even for a third molar removal. You have to mention whatever the outcome. It can be bad, that you can injure the lingual nerve, or you can cause a mandibular angle of the mandible fracture by exerting too much of force. That's why when I'm here, I like to tell you all one thing. I think many of my colleagues, my contemporaries will say yes, that the Winters elevator, the crossbar elevator, it's a beautiful instrument. When I was in undergraduate level, we were taught using that. But now, I think in Malaysia, we have all the institutions have stopped using Winters elevator. It's just like the criers, but it has got a very good handle, and your whole wrist, you like opening a handle of a door. So that one exerts the mechanical advantage of that instrument is great. Okay. And it's very dangerous if you don't know how to use it. So at my institution in Masa, we never advise, or we don't have that instrument, the Venter's crossbar. We don't use it because it can cause, if you use it wrongly and exert so much of pressure, because the MA is very, very high, and you can fracture the angle of the mandible, especially with your third molars or second molar. So be very careful. Always tell them that doing a third molar, I know when I do a third molar, I never go on the lingual side. I never raise the lingual flap, because it is quite difficult. Around your third molar in the lingual side, the lingual nerve traverses quite close, about 3 to 4 millimeters away from the crestal bone. And then as you go forward, it goes down. So please explain the potential risk and complications that can arise, and the duration of treatment, especially in orthodontics. The patient will ask, how long will I use braces? So, well, you have to give them a treatment plan that states that it may be 2 or 2.5 years before we can debond your brackets and give you a retainer. But if in between, if there's some change in the treatment plan, we have to advise the patient in the first treatment plan itself, that time may prolong if there is some change in the treatment plan. So get them to sign it, okay? And the most important thing, where like for outpatient treatment, especially like for normal extractions. See, the nurse, they will ask the nurse outside, how much will you charge me for a molar extraction? So when say the nurse will say, no, $100. Okay. But the nurse doesn't know that it may be a complicated extraction, or it may become a surgical extraction. So always inform your nurse. Give them a range. If it is just a normal extraction, it is $100. Or if it is complicated, where the doctor has to surgically remove the roots, then it becomes $250 or $300. So pre-warn the patient. So always after you have examined the patient, the dentist has examined, and he will roughly know. But even then, we have to tell the patient that if there is any procedure that is going to come more than a normal extraction, where I have to dissect the roots and remove the roots one by one, and then I have to put a suture. But anyway, for all molars, we put sutures. You have to explain and tell them how much it will cost, and let them agree. Always your nurse must be by their side as a witness, and also you can allow, if it's a underaged patient who is 16 or 17, then you can always allow the parents or the next of kin to be there, okay, so that you are safe. Okay, the patient can go on and tell, no, the doctor never told me this. Suddenly I come out, the nurse said $300. So we don't want that type of situations where there is other patients waiting in the waiting room, and this patient starts complaining. Oh, this doctor is a Lao China. In Chinese they will talk, or in Malay they'll say cutthroat or whatever. So to prevent all these unnecessary things, it is better for the dentist to tell the patient straight on the face, with, of course, with a witness. And it is always like, even for trying of dentures, I make the patient sign, and the next of kin is there, that the patient has agreed for the try-in. So I don't want any problem when you issue the denture. Okay. So always talk about the fees, and make sure that the patient agrees to the fees. Okay, we don't want any harassment outside. So this is another thing which is quite important. A pulse oximeter is very cheap, and you can just examine the patient's oxygen level saturation. Like a normal patient, it should be around 95% and above. But if it's below 92, please, you have to be extra careful. See whether it's dyspneic or, any other, your mind will run. We always now at this stage will run on to COVID. So examine, take the temperature of the patient, and in your counter, I know that is on COVID. I can't talk about it, but you all know the protocol, the SOPs to be followed. So once if you recognize any hypoxia, that means below 92 or 93, below 93, I will not take up the patient, especially during this pandemic. So this is a very simple examination, and you can always jot it down in your clinical notes. And please, when you're writing your records, I think even I had this problem when I was practicing. I used to use these short forms, but now I think in the court, it is not valid. Now, this type of records. I don't understand what is TAT PCM 10 under in brackets. So it doesn't really, it is not a proper prescription, okay? So this, I will call it as a poor treatment record. And that if only the dentist had told me, okay, that means that is the phrase usually told by the patient when they go outside to pay. Okay, so that was under, the cost. But dating is fine, 7th of May 2018. But XLA cross 4, upper left quadrant. So anyway, that one is acceptable. The quadrant thing is acceptable. But XLA, we are actually to write a clinical record, which is say extraction done under local anesthetic, and what type of local anesthetic, how many % you have used. And also now they want the batch number, whether it is expired or not. Okay, they want real clean records. So write down whatever you have done in like a small essay, just write down everything. And the prescription, please write paracetamol. I don't know how many grams he has given, whether half a gram or 1 gram or 1.5 gram, I don't know, just TAT PCM 10. So this means you tell the patient to take 10 tablets. So please be more specific when you write down your clinical notes. Okay, I know so some busy dentists, but now I think with the COVID, there are no busy dentists. But usually if your inflow of patients is very heavy, so you don't want to lose time. But please do not forget that seeing your patient in a rush, you may miss things. Okay, please be very, very careful, especially with medically compromised patients, those who are on anticoagulants. I'll come to that. See, like this phrase, why didn't the dentist tell me something had not gone according to plan? So that's why when you say the complications that can happen, please forewarn them. It may be not a good point for your practice. That means, oh, what is doctor frightening me with all this? But I think it is our duty. Then when something happens, this is what will happen. They will point a finger at you. You never told me this, and according to your treatment plan, whatever you told me, it was quite a simple procedure. So please refrain from short, and I think TAT PCM 10 is totally wrong. You must say how the prescription must be there. 2 tablets, that means 1 gram every 8 hours or every 6 hours. Okay, if like this, TAT PCM 10 is not proper. Okay, please pay a little more attention to prevent any negligence. And treatment consent, I've showed you here. Most of our cards are like this. Generally, it is like this. And I would like to stress on allergy. please write it in red. So if any locum comes to work in your clinic, and if the locum sees the clinical records, then he will know, he'll be careful. Have an individualized and specific consent for every treatment, like endo, ortho, oral surgery, whatever treatment you are doing, you have to have a separate consent. And after the patient has understood your whole treatment plan, then they sign the treatment for that specific endodontics or prosthetics or any other procedures. Okay. And especially the oral surgical procedures, absolutely thorough medical history is compulsory. Please talk to the patient. In my slide, you can see eye contact is there. The patient is listening. The dentist is concerned about the patient. And please ask a full history on any allergies, any risk of infective endocarditis. So they may have had a prosthetic mitral valve or whatever need for prophylactic coverage, so that you won't be caught with your pants down. You said, oh no, doctor, you never asked me. That's why I never told you. I just had a prosthetic valve 2 months ago. And if the patient in the history, very few of us ask for rheumatic heart fever. Rheumatic fever is usually in children, where the child who is 7 or 8 years old may have very high temperatures. He'll give you a history, or the mother will tell you that he was admitted to the hospital, but the fever automatically after 7 to 10 days disappeared. Okay, after that he was fine. So we have to think of infective endocarditis and of course the need for prophylactic coverage. Okay, if the patient is on dialysis, best to do the day after the dialysis, the next day, if you want to treat the patient. Okay, because they go every 3rd day for dialysis. So if you're done the dialysis, okay, for say today, tomorrow morning will be the best time. So I just want to tell you all which medical histories you all have to stress more often, because many of us, we fail to take a good history. Like pregnancy, you should be cautious, especially in the 3rd trimester. And patients on anticoagulants or antiplatelets, they are 2 separate things, but they work. How they work is different. Antiplatelets prevent clumping of platelets. They prevent the clot formation. But the anticoagulants prevents slowing down the clotting mechanism, where the end product is fibrin, stable fibrin. So like on warfarin, patients, many of our patients are on warfarin, those who are hypertensive or those who have been for any cardiac manipulations. So we stick to, if the patient is on warfarin, they will be carrying an INR booklet. So please, well, in my practice, I will not do any extractions or deep scaling for patients warfarin 2.5 above. But the textbooks say below 3 is fine. So be very careful and always think of the post-extraction bleeding. You want to have a good night's sleep after the extraction or MOS. So you must be very careful when you select your patients. Okay, always consult, seek medical clearance, always consult the cardiologist concerned. Okay, so I advocate that recent cardiac procedures, I'll wait for minimum 6 months. After that only we could undertake any bleeding, I mean like surgical things. So if a patient after the 6 months, even then I will give stat like 3 grams, 3 grams of amoxicillin, or if he's allergic to penicillin, I will give 600 milligrams of vancomycin or lincomycin. You can have your options. Of course, you have to give 1 hour before surgery. Okay, and yeah, so we must know our limits to prevent any complications. Like if you have accidentally pushed a root into the sinus, don't be shout. I mean, don't you yourself shouldn't get worried. Okay, you reassure the patient. Tell the patient the truth. What has happened? I see an implant in the sinus. You have driven the implant through the sinus floor, but it is okay. You have to reassure the patient, saying that what has happened. Okay, and make sure you do a good referral. See, I can go on talking on OAF or oroantral fistulas, but time is running fast because I got more slides. So like OAF or fracture of the mandible, which is not due to your extraction, or fracture of tooth which you can't remove the roots, please let go your ego and refer to a specialist. Always think of the patient. Okay, treat the patient with care, and of course you have to do the best for him, but you can always tell yourself, let your ego down. I'm not much trained in removing the root from your sinus. Anyway, I'm giving you preliminary precautions, and I'm going to refer you to a oral surgeon to remove the roots. You know, the old school of thoughts, some of them say you can leave the root behind, but if the patient has established an oroantral communication, and if the communication gets epithelialized, it is called an oroantral fistula, it will not heal. So every time it drinks water or gargles through the nostrils, there will be, the fluids will be coming out. So you have to close that. Okay. And if you're capable of doing a von Reichmann's buccal flap approach to close the OAF, if you have trained and you have been trained to do it, please do it. There's no harm in it. But if you are new and you are just starting in your career, I think you should always refer your patient. Don't hesitate to refer. When you are in doubt, don't be a hero trying it for the first time on your patient. So please keep in mind that to practice safely. Okay, that doesn't matter if you break your tooth and you can't remove your roots. You can, there is no harm in that. Many of us have gone through that. Okay, so OAF is here in your CBCT. It shows that the root has gone into the sinus, and of course you can trace the sinus with a Gadapaka, whether it goes into the, definitely it'll go into the antrum, but this method is mainly used for tracing the focus of infection. Sometimes the surgical trap comes where the pericoronitis or pericoronal abscess is from the 3-8 or 4-8, but the sinus, the abscess will discharge opposite your 6 buccally. So you will think it is the buccal tooth that is offending. But this is one way where you place in a Gadapaka cone and take an X-ray, you will see that the cone tip reaches the 3-8. So you know the foci of infection is the 3-8. And this is a diagrammatic, this one to show you how to close the OAF. Okay. So referred pain, toothache secondary to sinusitis, always. Pain is a very wide complaint, and you could always trace the pain. Like this pain, like osteoradionecrosis or osteonecrosis due to bisphosphonates. They are two separate entities, but they look at it clinically, they'll appear the same. But when you take a history, if the patient takes, say, every week I go and get an injection of bisphosphonates, that trade name is Fosamax, I think. And usually 70 milligrams they take daily or weekly injections. So you must be very, very cautious. If you don't know what is bisphosphonates and you just close your eyes and go and extract the tooth, you will end up with osteonecrosis. Okay, bronch they call it, like bisphosphonate induced osteo. Usually bisphosphonates are used for osteoporosis or hypercalcemia, bone malignancies, multiple myeloma, Paget's disease. The medical people will put them on it. But when you take a history, we should be very well documented in this one that this patient is on bisphosphonates. So very, very careful to deal with bone surgery. It will not heal. It will appear like this in the patient. After the first week, it comes back with pain. You can see exposed bone, slough, yellowish bone exposed, osteomyelitis, like osteomyelitis. But bronch is very common now these days because a lot of patients, seniors who are on the treatment with Fosamax, they will have to tell you, you have to take it out from them. Okay, please keep your eyes open and take a good history. Well, you have some of us who are just dentists, general dentists, who would like to use nitrous oxide. Of course, you can use, it is very safe, but you must be trained. Okay, please, these are the two things that we always recommend. Now the Ministry of Health has put this in under the private healthcare, oxygen tank with nasal mask or the whole nasal oral mask. And we have the AMBU bag. Now they have that artificial manual breathing unit. Formerly it was called AMBU. Now it is called the artificial manual breathing unit. One-way air into your lungs. Okay, so this is compulsory to be kept in your practice, whether or not you're doing a specialized practice. A specialist clinic who is in mainly oral surgery, implants, they should have. But this nitrous oxide is good because there are two tanks. One is pure oxygen and one is nitrous oxide. And you can control. Usually we use that with 70% oxygen and 30% nitrous oxide, which is very, very safe. And you want to give oxygen flush, you can use this by switching off your nitrous oxide at the end of your procedure and flush them out with your oxygen. And if you are practicing many cases under this nitrous oxide, you have to have nitrous oxide gas as it takes away the nitrous oxide in the surgery. So it is safe for your nurse, for you. Okay. So please make sure that you are well trained in BLS, at least the basic life support. And AMBU bag, of course, you have to have it. Now it's a requirement. And the best thing is automated defibrillator. Okay, that is very, very easy to use. And it's foolproof. You don't need to do anything. Everything will be told what to do. And this, I know many of my colleagues have told me that this is not available in Malaysia. You can't buy it. That is the adrenaline shot, which can just single use 1 milligram in 1 ml. You just puncture into the thighs or anything in case of any allergy. And if the blood pressure is dropping, it is good to have this, but it is not available here. We only have vials, adrenaline vials. Please keep them in your emergency cupboard. Okay, always emergency drugs should be kept under lock and key. I mean, I no need to go through. GTN is a must, and salbutamol inhaler. You can keep tablets or inhaler is faster acting, sublingual. And even our GTN, please see the expiry dates. Sometimes we forget, and we just, because we don't use it so often, we forget to check. But please check and make your nurses write the expiry date in big bold letters in the cabinet so that you know when it's expiring. So please keep these necessary emergency drugs so that you have at least shown the court that you have taken the steps to resuscitate the patient. All right. But of course, the second thing you do when an emergency happens is to call 911, activate the emergency medical service. But these things, basic life support, anyone can do it. But the compression rates have changed now since 2016. It is 100 compressions or 120 compressions per minute, which is quite strenuous, but you have to do that. Otherwise, your compression is not effective. It will not push the blood from the heart, from the left ventricle, through your vertebral arteries and your internal carotid to reach the brain. So please, make sure you have got good compression. If you attend a course, they will show you, they will stress to you. And on July 11th, we are going to do that with Prof. Ali from MASA, Emergency Medicine. And that is, we have planned it as a face-to-face, but I think that is very, very important for a dentist. Okay, radiology, again, now they want us to include pregnant women. So you have to ask a history for LMP, last menstrual period, to know whether she's pregnant or not. So you have to put the signage under the Private Healthcare Facilities and Services Act. We have to put that thyroid shield. I don't see in many clinics, but it is advisable. And of course, you have to put up that danger sign, you know, with the 3 black blades, that sign that is hazardous. You have to put up those things in your clinic. Otherwise, you won't renew your license. So please be careful. Now, these are all latest things and procedures. Explain and document your treatment plan, of course. Discuss the treatment cost, specialized consent, and impression taking and making. So an alginate or a impression with alginate to just make a study model is impression taking. But when you do a final bridge, or you're taking it as a final impression, even in full dentures, we call it impression making. So gag reflex, again, is a big problem in your practice. So always do the lower impression first, and then do the upper, and keep the patient upright for your upper. Okay, that all is there. Consent for try-in. Yeah, that one I stressed it earlier. Of course, when in doubt, please refer or call up your colleague, call up the medical doctor or call up the physician. Okay, and to make it easy for you all, we have in our clinical appointment book, we have got pages on refer to the necessity specialist, the specialist name, telephone number, and their clinic address. So you could, that came in handy. Now we have, since we have added all that in. And prescription writing, as I said, PCM 10, that is not a prescription. Please write a proper prescription with everything, a full prescription with name, address, and the directions. Like example, cap amoxicillin 500 milligrams 3 times a day for 5 days. And please, I want to stress here that please do not write prescriptions for 3 days unless you are seeing the patient on the 4th day. Okay, if you're just writing a prescription for a dental abscess and he goes away, or periodontal abscess, don't write it for 3 days, please. We are inviting more resistant strains, and a normal prescription for antibiotics should be minimum 5 to 10 days. Okay, depending on the severity of the infection. And please select the proper antibiotics. But amoxicillin, but I find amoxicillin or clavulanic acid with clavulanic acid, that is called augmentin, very, very helpful. It's a BD dose. And some for severe infections, I also gave 2 BD for the first 2 days, so that the infection will come down very fast for the first 48 hours, and then continue for another 5 days on 1 BD. And always end your prescription by writing this note, not to be repeated. So they cannot use the same prescription and go out to the pharmacy after 3 months and try to get them. And the pharmacist also will take away this prescription. Okay, and always there'll be a duplicate in your clinic, and the main one, you give it to the patient, and you write there not to be repeated. And your MC books, please, my colleagues, I have seen, usually in the government MCs, you will see that this cert does not allow you to be absent in court, from court, you know. So some people just come to you malingering that they say they had severe toothache. Please examine the patient, record the patient, get a file, and please see the patient on your chair. Don't just sign a blind medical certificate or pre-signed medical certificate books, because there are reports that has happened, that doctors usually pre-sign their medical leave book. Please do not do that. That is against our ethics. So you can see if you have done an extraction of a tooth, then of course you can, can give them for a day. And if you do a surgical removal, you can give them for 3 days in a row, but not more than 3 days. You have to see the patient after 3 days. And if he comes back and tells you he's still pain and there's still signs of inflammation and infection, then you can continue for another 2 days. So please do not give them one shot for 1 week, okay? Unless you are in the hospital treated by a maxillofacial surgeon. But in a private practice, please don't give more than 2 days if you've done a third molar. So avoid negligence. I'm going to sum it up. Okay. Clinical error is human error, of course, but that human factor should be reduced. You have to go for training and competence. Please attend CPDs, continuing professional training, and you select your cases. Poor case selection is one of the leading causes for failure of treatment. Okay, and then your consent process, take a good consent, and you have to prepare separate consent forms for every, as I said earlier, for every treatment. Okay, and patient's expectation not met. That is where the patients start to complain. So you have to have a good rapport with the patient, and also make sure you have explained it well. And try-in is not as simple as it is. What we do, we take the waxed denture and we put inside mouth and give them a mirror. That is not try-in. It's as simple as that. You know, that the shade selection, especially anterior maxillary teeth, they can be very, very fussy. So you have to really, if they say white is black, you have to accept light for your shade selection. So let them choose the shade under sunlight near the window, or you try to guide them and tell them to look at it properly, look at it with their own natural teeth and compare the shade. So shade, hue and chroma. These three things have to go in hand. So please pay a little more attention so that you won't be disappointed. And if at all during issue, when you are going to deliver the denture, if the patient is fussy about the shade, I think I will tell the patient that I'll repeat it. Okay. Don't start arguing with the patient. No, you have already signed. You said, okay. But it is a good practice to satisfy the patient. Say that I will redo your denture. I'm so sorry that but I know you have accepted it during try-in, but I don't want the patient to go out grumbling and the other patients in the waiting room seeing the patient, a dissatisfied patient will always try to bring out his anger by telling other people in the clinic. So I always try to solve any grievances within the clinic walls. Try to, rectify it there and then. We don't want it to go on. Okay, so your other patients, they can hear it when she comes out. She will tell them, hey, these dentists are cheating now. So we don't want this. So try to finish your complaints and try to satisfy the patient within the 4 walls of your surgery. Reduction to challenge. Your reaction to challenge, do not do that, because if you try to challenge or be harsh, they also will feel bad. And please do not comment on your colleagues' work or whatever. You just ask them, how old is this restoration or whatever is it? Have you been using it for some time? I don't ask for, criticize your colleagues. Or no, I will say whatever the dentist has done, he has he has done the best for you. But since over time, there is wear and tear of these dentures. So I think you need to do a new one. If you want, you could go back to him, or we can do one for you. But any complaints about a treatment done by another dentist, don't criticize it. Just advise the patient to go back and see the same dentist so that he can correct it for you. All right. So that one I have spoken about behavior in and out of surgery. For you, for the patients, that you are a well recognized person in the clinic and as well as outside. So our conduct outside should be also be good. What I say that patients look up, they think that medicine and dentistry is a noble profession. So what I'm going to do is now I'm going to go to the next slide. Wait 1 minute. Can't go further. Give me a small break. Yeah. So what I will do is we have to be very, very cautious when we practice. Of course, you don't want to have a headache when you are gone home after your treatment and the patient calls you at night. That some dentists don't give their handphone numbers. Anyway, because they don't want to be disturbed outside, but it is wrong. I think I give my handphone numbers to my patients. If they want to call me at night, they can call me if they are in pain or what. I can at least do tele-dentistry, how to solve their problem, if I can. But I think if you're doing more on oral surgery or implants or even endodontics, the patient should be able to contact you. But some say, no, we are spoiling the patients. They'll call you at night, 2 a.m., 3 a.m. But I think we are due. That is due to the patients, the patient care. It is not only in your working hours, but after your working hours, you should be available. Okay? Keep up with your competency. That means by attending workshops and maintain basic standards of treatment care. So we will be now, when I'm at this, the standard of treatment care, at our time, it was Boehm's theory or whatever they call it. They standardized it as Boehm's. But now the British Dental Council has brought in, of course, you all have heard of it, Whittaker, Roger and Whittaker. So our competency and care you have given to the patient is based on this theory. That is not theory, it is actually a case, and they have put it at this competency level. So please keep yourself updated. Don't stick on to just GV Black's classification. Now they have come out with ICDAS, which is, I find ICDAS very absurd. But, you know, in the teaching scenario, you have to follow the trend. So we teach GV Black's classification of caries, and we also do ICDAS, International Caries Indicators. So keep up to date with your expertise and constantly acquire and develop new skills. So new materials are coming in, and have adequate knowledge and experience to know that something is not right. That will come to you automatically, and you will be more keyed towards your, especially when I'm telling about myself, when I first started practice on my own after the government service of 2 years, you know, I was a bit cautious. I was very frightened, and but after 5 years, then you are on a smooth road. So be very careful. Don't blindly just think of the dollar sign and go straight to a crown and bridge without systematically examining the patient, whether he is fit for a bridge or whether a long span bridge with 2 implants, which is a no. And implants, if you have acquired the training, and many of us have gone through trainings and workshops on implants, and I feel many GPs are very, very good, and their standard of practice is good for their implants, and they're doing well, have adequate knowledge and experience. Okay, experience will definitely put you in a higher step. A willingness to acknowledge you are getting out of your depth is also very important. Your ego. Don't just attend a 2-day workshop and then come and try to do a 5 canals molar endodontics. Of course, you won't be very capable, and you have to go for training and experience doing it with microscopes. That will enhance your practice. So always keep abreast with the latest developments and attend CPDs. So what I will do is I'm going to tell you all that we are having upcoming events and lecture series. The next one, we have postponed it to the 11th of July because of this MCO. And the next thing will be coming up is with basic life support, which will be demonstrated to you, but you can't get any basic life support certification, but you will know it is happening on the stage when you're watching. And there'll be a lecture on basic life support. And we have an open forum with the question and answers, the role of practitioner in the private health facility. So that is by Dr. Hasnita. She's with the oral health division, and she is going to give you all an open forum. And early in the morning, I'll have a very short session on risk management in clinical practice. We are scheduled it to the 11th if everything is okay. No, one. And that is, we are going to have it. Actually, we have already booked and paid for Sunway Lagoon Club. And please, the flyers has already been sent earlier. And we have notified you all, our members of the Malaysian Private Dental Practitioners Association, to be in touch with us to this upcoming dental lecture series. Okay, thank you very much. And I hope I've given you all a substantial insight into how to practice safe dentistry. And I would like to comment here that I want to thank you all for attending this session. If you have any question regarding safe practicing, regarding clinical work, what are the steps to take, precautions which I may have missed because of time constraint, I want to put back it to Dr. Priyanka to go on with the Q&A if there is any questions. Thank you so much.